Okay, hello everyone. I'm here to give you an overview of suicide in Canada and particularly to focus on the work that we're doing with the Canadian Association for Suicide Prevention. Could I have the next slide, please? Now, because this is sometimes a challenging topic, I'd like to remind you of a key piece. When we work with the Canadian Association for Suicide Prevention, an awful lot of our focus is making sure that we as practitioners and also the people that we're working with are able to keep hope alive. So if your determination is sick, I do not counsel you to despair. Great works are performed not by strength, but by perseverance. And that's the work that we're all doing. Could I have the next slide? So in terms of the burden of suicide in Canada, and certainly John has provided you with some of this information, but we know that there are plus or minus about 4,000 suicide deaths in Canada every year. In 2009, it was reported that we had 3,890 suicide deaths, which is more than 10 a day. We often hear the metaphor that it's kind of like a jumbo jet crashing every month in this country. And that gives us a rate of 11.5 per 100,000. We're the 19th of 34 OECD countries with respect to our suicide rate. Again, if you absolutely trust the statistics, and of course we know that there are challenges with those stats. But in Canada, it's our second leading cause of death for Canadians that are 10 to 19 years old, and the 11th leading cause of death overall. It does vary by province. So for example, here in BC, where I live, our suicide rate in 2010 was 11.7 per 100,000, or 530 people. It was 8.5 per 100,000 in Ontario. It was 57.1 per 100,000 in Nunavut. Now, worldwide, we know the World Health Organization tells us that we lose 1 million people or more by suicide every year, and that is more than any other type of violence, including armed conflict. When we talk about suicide rates, we're talking about death, but we know as well that suicide attempts have a significant impact. And again, it's hard to know exactly how many there are because we're really going by what gets reported when people go into an emergency ward. But the estimate is that there are 20 attempts for every death. If I take just a very small snapshot, in 2004 in my own province, the economic costs, both direct and indirect, that were associated with suicide and self-harm were $346 million. And we know certainly that for everyone who dies by suicide, there are at least 6 other people close to them who are profoundly impacted. Now, these statistics, I think, remind us of something very important, and that is that the real challenge here is that suicide is for the most part preventable. We're talking about preventable deaths here. Could I have the next slide?
Slide 17.
Okay, so if we move to the next slide, I want to speak just a little bit about some of our challenges with respect to vulnerable populations. And one of our most vulnerable populations in Canada are our First Nations, our Inuit peoples, and our Métis. The suicide rate for our Inuit youth in the north is among the highest in the world, 74.9 per 100,000 people, with our young males between the ages of 1 to 19, 25 times more likely to die by suicide compared to the normal average for same age in the rest of the country. For young Inuit women, 1 to 19, they're 22 times more likely to die by suicide. And the suicide rates for our First Nations youth, so that's non-Inuit, non-Métis, are somewhere between 5 and 7 times higher than for the general population. We know as well that suicide among Aboriginal women is at least 3 times the national rate compared with the national average. But I think it's really important that we have the reminder that there are comparisons that have been done across the country with various Aboriginal communities that reveal some major differences across those communities. In some, there have been no recent deaths by suicide, whereas others report extraordinarily high rates. And if you'd like to understand the studies that are being done around that work, I would recommend you to a paper that's been written called Cultural Continuity as a Hedge Against Suicide Risk by Chandler and Lalonde. And I've provided you a link to that at the end of the slide. Next slide, please. We know as well that men are much more likely to die by suicide than women are, certainly 3 to 4 times as likely. The rate for Canadian men was 17.9 compared with 5.3 3 for Canadian women, and yet women make somewhere between 3 and 4 times more suicide attempts than men do, and are hospitalized about 1.5 times more often. And we believe that the reason for that is that men remain more likely to choose what we would call immediately lethal means. We know that older men, older white males in our country have the highest rate of suicide in Canada. The 2009 rate for Canadian men between 85 and 89 was 30.6, compared to an average rate for the general population of 17.9. And Statistics Canada tells us that between 1980 and 2008, the suicide rates are increasing among female children and adolescents, and they are decreasing somewhat among male children and adolescents. This is a cause for concern. I can tell you anecdotally we're seeing many more deaths by hanging for young women than we would have seen even 7 or 8 years ago. Next slide, please. Again, when we look at vulnerabilities, certainly mental health and addictions. 90% of those who die by suicide struggle with a mental illness, as John mentioned, major depressive episodes, substance use disorder, and schizophrenia. And as John had pointed out, it's the most common cause of death for people with schizophrenia, which we may not hear as often because that diagnosis would be given to approximately 1% of the Canadian population. But still, that's what's taking most people from us. Next slide, please. And I think it's also important, there's a real tendency, and I'm a social worker, so I always need to remind us that the medical model is one way of looking at suicide, but it's very important to look at what we would consider to be the public health issues. We know that socioeconomic deprivation produces much higher suicide rates among children and adolescents. We know that suicide is a complex issue that is produced out of a number of interconnected factors: individual, environmental, biopsychosocial, cultural, historical, political, spiritual. And certainly it's most important that we pay attention to psychological trauma, both developmental and intergenerational. And that's been produced by some unique conditions in Canada that include marginalization, institutionalized trauma, colonialism, racism, prejudice, acculturation, and homophobia. And these things have certainly contributed to First Nations, Inuit, and other marginalized populations, our gay, lesbian, bisexual, transgendered, two-spirited, queer, and questioning people having higher rates of suicide-related behaviors. And suicide prevention, when we move into prevention work, it spans that continuum of mental health promotion, prevention, intervention, and postvention. Another way to think about that is the importance of any work that we do in terms of promoting, protecting, preserving, and sustaining life. Another way to think about that is that, yes, it's key that we intervene in acute situations, but what really helps people stay alive is the belief that they can build lives worth living. And so much of our work needs to be focused on supporting people's capacity to build lives they really want to live. Could I have the next slide? So, it has long since come to my attention that people of accomplishment rarely sat back and let things happen to them. They went out and happened to things. Now, my computer told me Leonardo da Vinci said that. I find that a little hard to believe, but I like the quote so much I included it anyway. Next slide, please. So, I suppose that the Canadian Association of Suicide Prevention, you could consider that we decided to go out and happen to things. We were incorporated in 1985 with a vision to reduce suicide risk and minimize the harmful consequences of suicidal behavior. And we have been doing that work since that time with an extraordinary limited budget of about $40,000 a year and a crew of incredibly skilled and dedicated volunteers. And all of us with the association are volunteers. Our functions are to facilitate information sharing with respect to both intervention and research, to push for policy development federally, provincially, and territorially, to support the development of excellence in research and share that across the country. And we work to achieve those purposes by facilitating, advocating, supporting, and advising. I would add jumping up and down, rather than providing direct service. Next slide, please. How are we structured? As I mentioned, we're voluntary with an elected board of directors. Most of the provinces and territories are represented on our board. Our headquarters is in Winnipeg, Manitoba, and we're given that space by a community health organization called Clinic as an in-kind donation to us. And membership is open to everyone, and certainly includes people who've lost someone to suicide, people with lived experiences related to being suicidal or being in contact with others who have experienced suicidality. There are professionals, frontline staff, researchers, policymakers, students, volunteers. The bottom line is we're connecting with anyone who's concerned about preventing suicides and improving the quality of life for all Canadians. And if this sounds like you and you're not a member, you should join us. It's not very expensive and it's an incredible contribution. And right now there are about 200 of us across the country. Next slide, please. This is a picture of what it feels like to try and get Canada to adopt a national strategy for suicide prevention. What you don't see is that we're a lot closer to the top than we have been in the past. Could I have the next slide? So in 1996, CASP developed something that actually informed national strategies for suicide prevention all around the world. It was called the CASP Blueprint. And in 1999, the World Health Organization, and again in 2002 actually, World Health Organization launched global initiatives saying that all nations should develop suicide prevention strategies that evaluated national policies and practices for suicide prevention. And our blueprint that CASP has developed with extraordinary amounts of labor by very skilled people on a voluntary basis informed a number of national strategies around the world. If you want to take a look at it later, there's a link there. It's a national suicide tool, it's a policy agenda, it's a task list, it identifies best practice, and it's a roadmap to an integrated solution. It's evidence-informed, it's comprehensive, it's professional, it's practical, and there has been no uptake of what has been a free gift to Canada at the federal level, really not up until now. If you want to take a look at some of the strategies that are informed by that blueprint, again, there's a link there for you to go and take a look at. But the bottom line is we have a blueprint in place. It just hasn't been picked up and adopted at the federal level. Next slide. It's important, though, that we're able to celebrate any progress and not wait to get things perfect, and certainly I would support that belief wholeheartedly. Next slide. Some of the progress that we're celebrating right now is something called Bill C-300. It's a private member's bill that Harold Albach introduced to adopt a national suicide prevention framework, and right now that bill is in final reading in the Senate. In fact, I got an email today asking if CASP would be willing to come and testify before a Senate committee. Now, the bottom line is that CASP and the International Association for Suicide Prevention and many others asked for an awful lot of improvements to that bill to strengthen it. And unfortunately, none of these amendments were accepted or adopted. So the reality is that when this legislation is passed, because it needs an awful lot more support than currently exists in it, we're going to have to do some things to give it legs in order that it be a comprehensive federal, provincial, territorial, public, and private response to suicide prevention. Next slide. So what do I mean by legs? Well, what you'll see there is we want really strong and powerful legs to make Bill C-300 actually make a difference in the lives of Canadians. Next slide. Some of the examples of what would need to be in place to give that bill legs, well, we'd like clear, measurable objectives that were reported back to the nation on a regular basis, similar to what's happening in Scotland right now. We'd like specific policies that are targeted to reducing access to lethal means, because we know that reduces the risk of suicide. We'd like guidelines and action initiatives with respect to public awareness and knowledge and education, gatekeeper training. We'd like better information systems so that we not only have more effective statistics, but they're reported back in such a way that people know what's going on a yearly basis with respect to suicide and related risk factors. We need more encouragement for research to advance and share evidence-informed knowledge and program evaluation so that we would have in Canada a best practice registry for suicide prevention, intervention, and postvention. Next slide. More legs. So we want a centipede under Bill C-300. We'd like Canadian suicide prevention guidelines, certification and accreditation, improvements to service provision, improved support, because there is so little right now in Canada for those that are impacted by suicidal behavior and completed suicide, the promotion of trauma-informed care and practices, support for creation of networks and community of practices, including a national distress line network and a national suicide bereavement support network. And we believe that all of this would work an awful lot better if we had funding for a national coordinating body. Next slide. So bottom line is what we're talking about, how can we work as a team? And the way a team plays as a whole determines its success. You can have the greatest bunch of individual stars in the world, which I believe we do in Canada. But if they don't play together, the club won't be worth a dime. Next slide. So in response, thinking about how we could work together, in cooperation with the Mental Health Commission of Canada and CIHR, in May of this year, we pulled together the first meeting of something called the National Collaborative on Suicide Prevention. And that first meeting was attended by about 70 participants from 45 national organizations, all of whom had some kind of stake in suicide prevention, intervention, or postvention. And our intention was to look at how we could reduce all of the fragmentation and duplication that exists across this country, how we could connect all of those pockets of promising practices and share what we know and build on what's working to get better all across the country. Next slide. Where are we with that now? Well, we've had an initial meeting and there was an awful lot of work done to start building those connections to enhance our capacity and share knowledge. And out of that, again, with wonderful support from the Mental Health Commission, we actually were able to build a website for knowledge sharing. And again, I've provided you with that website. And there are currently discussions. In fact, our executive director met in Ottawa with Mental Health Commission folks and Public Health Agency of Canada folks last week to look at tripartite leadership for this national collaborative on suicide prevention. So we're doing our best to move that joint effort forward. Next slide. So the secret of getting ahead is getting started. And that's what's really key, is getting started. And in order to do that, we have to break things into manageable size. Next slide. Here are some of the ways we're trying to do that. What this slide explains is that we're working right now to pull together a Canadian distress line network. So all the distress lines in the province are part of a group that will support all of them, that will enhance their knowledge exchange, that will support their capacity to effectively manage not just the current and emerging challenges, and some of those are certainly around things like social media, to enhance evidence-informed practices, and to try and have a single number for emotional distress that anyone can use all across the country. And that group is on its second meeting now and working on a third. Next slide. We've also begun to work on the development of a national suicide bereavement support network. There has been some work sending out a questionnaire to groups doing that kind of work across the country, asking them what they're currently doing, what they wish they were doing, what would need to happen so they could build on what they know. And so we've begun that work to make that linkage. Next slide. So we're beginning. Coming together is a beginning. Keeping together is a process. Let's hope we can do that. But it will be our working together that will be success. Next slide. If you want to learn more about any of the things I've been talking about, here are some links to really key websites that I think you'll find really interesting around this whole topic of how do we work collaboratively to improve our responses to suicide risk in Canada. Thank you very much.